orthopedics. Here on the screen, a case of posterior interosseous nerve palsy. We operated recently together with Dr. Mohamed Al-Nordisi here in Shifa Hospital. We will exclude the injections, anesthesia, and the accident of radiation, as well as the cranial nerve lesion, spinal accessory nerve lesion, and we will speak only about orthopedic surgery and iatrognic lesion, surgery induced. The orthopedic surgery provides a lot of that sort of injuries, and our series now is about 200 cases operated by me and my team, and I will give you some example of my experience and the conclusion to prevent such injuries. So we have not always a complete lesion, grade 4 on 5 lesions according to Sunderland's classification. We may have some block injuries, we may have some recovery. So it depends on each type of surgery, and surgeon experience is needed to provide an opinion, to give an advice if you have such a complication. And the best is to ask this advice as soon as possible after the statement of such a iatrogenic paralysis. So the radial nerve and the medial nerve are the most impaired nerve in our series. But the etiology, the main etiology, this is the schwannoma. The schwannoma is a bedding tumor of the nerve, and if the diagnosis is not performed preoperatively, you may operate a tumor, remove it as a lymph node, suspecting a lymph node, for instance, and you will produce a paralysis. So what is very important, if you have a tumor, whatever the area in the body, if you have a tumor, if you palpate this tumor and you produce paresthesia, that means that it is a nerve tumor. This is pathognomonic of a nerve tumor. And more than 90% of these nerve tumors are schwannoma, bedding tumors, which can be removed without producing any nerve deficit, sensory or motor. So the technique of removing this tumor has to be known, and if you don't know, you close and refer the patient to those patients. This schwannoma you can find everywhere in a patient. If you discover intraoperatively such a tumor, if you know how to remove it, it is easy. You incise the tumor, preserving the nerve fascicles, which are not impaired, included into the tumor. They are put on the side, they are not included. So if you incise very, very gently, you can split the tumor inside the nerve, and you will not produce any deficit. It is simple to be done, but you have to know the technique. If you discover a tumor, and if you are used to remove, do it. If you are not to remove, close the patient, close the wound, and refer the patient to a specialist. Please don't perform any nerve biopsy. By doing this biopsy, you will get some healthy fascicles, and you will produce a nerve deficit, sensory or motor. No biopsy in the nerve tumors. For the medial nerve, the main reason of the paralysis, this is the so-called endoscopic carpal tunnel release. Many nerves have been kept using this device, and to my opinion, endoscopic carpal tunnel relief has not to be performed anymore. Open surgery with a small incision, 1 centimeter enough at the palm, is enough, and it is 100% safe. The cutaneous branch of the median nerve is frequently impaired when you perform a decompressive incision at the forearm and the palm. Please, if you have to perform such a decompression at both levels, don't make this continuous incision, which will cut systematically the cutaneous branch of the median nerve. This is a delicate problem of the distal rupture of the biceps tendon. If you have a distal rupture, please perform the reinsertion using two approaches. The small one on the border aspect of the elbow, and you pass the tendon in the anatomical sheath of the biceps tendon. You close the skin orally, you flex the elbow, and with a postural approach, it will be very easy to pull the tendon and to have it fixed on the radial tuberosity. Please use two approaches. So now we come to the radial nerve, which is very, very frequently impaired after radial fractures operated or around the elbow. But plate removal, elbow arthroscopy, and osteosynthesis of the proximal part of the radial head or removal of the radial head. So the lateral approach has to be absolutely avoided when you perform orthopedic surgery at the proximal radius. You see here the scar, and the scar is exactly crossing the normal place of the radial nerve of the posterior intraosseous nerve. The lateral approach is not the approach for the orthopedic surgeon. This is the approach for the posterior interosseous nerve. Many cases for such procedures have been operated by me and my team, and all these procedures, the proximal part of the radius should be performed using the posterior approach, the approach to the short extensor of the elbow through the anteromeus muscle. This is an example of about many cases of posterior interosseous nerve palsy. There is no extension of the fingers, and the motion of the wrist is preserved. This is the typical paralysis. This is the approach of the posterior interosseous nerve. You see, this is the lateral approach. You have here the extensor carpi radialis brevis, here the extensor of the fingers, and by following the septum between these two muscles, you will approach the supinator muscle, the superficial belly of the supinator, with a very typical oblique fibrous tendons. By incising the superficial belly of the supinator, you approach here the posterior interosseous nerve, which is a good nerve to be repaired when it is severed, because it is a purely motor nerve, and on the other hand, the repair is very close to the target muscle. That means that the renervation of the muscle will occur before the degeneration of the motor end plates. If you are in an area dissecting a place, you are afraid of a nerve, a normal nerve, you can use the stimulator to see exactly where is the nerve and to avoid to damage it. Here an example of non-union of the humeral fracture, and you think that the fracture is the reason of the paralysis? No, this is not the reason. Here it is the union, and here this is the neuroma, and the neuroma is exactly at the place the surgeon put the external, the K-wires for the external fixation. So be very cautious when you use external fixation, when you use screwing for locking nails, be very cautious. And what we have to recommend is to perform a long approach even if it is recommended to use percutaneous screwing. Here an example of radial palsy. So we made a study about the different days, locking days, proximal and distal for humeral fractures. And what we observed is that there is no 100% safe area. So a surgical approach, not a very long one, but enough to control that the nerve is not involved in the approach. Surgical approach is necessary for distal screwing and for removal of the locking screws. Same for the proximal locking. We have operated several cases of definite axillary nerve palsy and definite musculocutaneous nerve palsy. Here, case of a nerve tumor after brachial plexus. This is a typical C5 palsy with the paralysis of the shoulder and atrophy of the muscles. A more rare lesion, this is the iatrognic lesion of the femoral nerve during the procedure for a total hip replacement. And you see here a burn injury from the cement of the femoral nerve and the nerve grafting which has been necessary. So in our series of about 400 cases now of iatrogenic nerve injuries, this is the operative findings in many cases we have a complete section and partial section and fibrosis and infarct. But what is very important is what surgery we have performed. We have performed a lot of nerve grafting and only a very few cases of simple nerve suture. This is the problem. What does it mean? What is the significance of the difference between the two types of surgery? The difference is that the patients are referred to late to the surgeon. When you have a recent nerve lesion, such as a cut injury, it is easy to perform secondary suture. And the result will be much better if you compare to a nerve grafting. If you refer the patient to late, at the proximal nerve lesion, you will have neuroma. And this neuroma, this scarring tissue, has to be removed. And so you have a big gap, and it will be not possible to perform a direct suture. So one of the conclusions of our experience is please refer the patient quickly to the specialist. Here an example of schwannoma removed from the axillary area with a complete severance of the ulnar nerve, and this patient has been operated after 1 week, and it was possible to perform a direct suture with the final good results. So how to prevent iatrogenic nerve lesion? Please, when you have a tumor, look for the TNL sign. If it is a TNL sign positive, this is a nerve tumor. The surgeon must know the anatomy. What does it mean? That means that at the level of the neck, if you have to remove something you think to be a lymph node, you have to know the anatomy. You have not to cut the spinal accessory, and you have to know the anatomy of the neck. A long incision have to be performed to remove things and systems. So you have to look, you have to control what you are cutting. Long incisions are necessary for the exposure of some risky area to remove a plate, for instance, of the humerus. First, to prolong the previous incision in the lateral elbow area, control the radial nerve, dissect the radial nerve from the proximal to the distal, and after that you go to the plate and remove it. Use a neurostimulator if you have in the place you have some nerve you are afraid of impairing these nerves. Introduce K-wires through small incisions instead of percutaneous. Be aware in arthroscopy to produce a good distension of the cavity before introducing the arthroscope. Long incision to remove some implants. Some implants has to be removed by a senior surgeon, such as a plate on the lateral aspect of the humerus. For the surgery of proximal radius, prepare the posterior approach. In case of intraoperative nerve lesion, refer immediately to a specialist for immediate repair. In case of postoperative nerve deficit, refer immediately to a specialist.